gonna go.
Good.
All right, well,
Okay, other people will catch it later.
Sure.
No worries.
I get the sense that most people here know each other, but maybe not everybody knows each other, so I'm going to at least go through the motions here. I'm Philip Wainwright. I'm the Vice Provost of Global Strategy and Initiatives at Emory University. Emory has been privileged to have been one of the founding members of, I can never remember what the acronym stands for, but the Atlanta Global Research and Education Collaborative. I should remember that because I was there for the first discussions, but we're very proud to have been part of that, and it's otherwise known as AGREC. And AGREC's mission really is to pull together people from different institutions and organizations in Atlanta to study or take action on topics of global significance and that are globally connected. And so today, session, Improving Health Outcomes and Research Through Community Partnerships, is one of the projects that was funded by the AGREC mechanism. And it's my pleasure today to introduce the moderator of this panel, who's devoted her work to improving health outcomes in Clarkston. Dr. Mary Helen O'Connor oversees community engagement as a member of the Georgia State University Prevention Research Center team. Dr. O'Connor is also director for the Center for Community Engagement at Perimeter College. Her teaching and research in the field of migration studies, education and rhetoric, and composition explores refugee, education, agency, and identity. For more than a decade, Dr. O'Connor has been a volunteer and advocate for refugees and immigrants in Clarkston, Georgia, one of the largest resettlement communities in the U.S. Thank you.
I forgot to update that, Diane. It's 2 decades now because I had some birthdays. Thank you all for being here. I'm excited to be here with some of my favorite collaborators who have now become friends. And I'm going to let them introduce themselves and tell the story of how we met. So, Stephanie Brown-Bryant is the principal of Indian Creek Elementary, which is the elementary school across the street from the campus where I teach. Whatever you want to do.
I guess that's Anna Gibson. Good morning. I'm Stephanie Brown-Bryant. I'm also known as Principal BB. I'm the proud principal of Indian Creek Elementary School in Clarkston, Georgia. I have approximately 930 students, and as I sit here right now, I'm thinking, what are they doing right? But we have more than 40 languages. My top languages are Burmese, Nepali, Amharic, Arabic, Pashto, Dari, Farsi, Swahili, Tigrinya, a whole bunch of others. I'm from South Georgia, so those were definitely not common to me when I became principal. But during the pandemic, it was very difficult. And within our population, I only have about maybe of those 930 students, 700, more than 700 come from families who are refugees. So what I did not know, and even though the pandemic was horrible, it really did bring to light a lot of gaps that we needed to take care of because of our children just did not get what they needed. What we learned is there were not adequate services for not only our parents but for our children and getting them the information that was not only timely but met their cultural needs to be responsive in the pandemic. So I was sitting at my computer, and I literally would cry every day because what people don't understand is it was very important for us to get computers to every child. Well, one, our parents don't have internet, and this is probably too much information, but even when we sent the computers out, some of them were so infested with bugs that we couldn't use them anymore. Those are the conditions that our kids are in. And once we got them internet and we had a camera, a computer in every house, I cried every day because I could see in every house. I saw there was no food. I saw there were children. There was one particular child. Every day I would see feet next to him kicking, and he was a second grader. Well, his parents went to work, and he was home with a 6-month-old every day as a second grader. So I got this. I was on my computer, and I had been just emailing people for help. Like, can we get computers? Can we get someone to help translate? How do we inform the parents that we need about COVID? How to recognize the symptoms of being sick? And someone said, there's this lady in Clarkston who they're going door to door helping families to learn about what the symptoms are, how to get help. So I emailed, and finally we got connected on a phone call. I said, I've been looking for you. I need some help. And I could just feel myself, like I wanted help so badly, just to be able to connect in a way with parents and families who so desperately needed the help. People were dying. I have a mother, she was a mother of 14. She died. And the father is incarcerated. So we were left to try to identify ways to help. So the partnership, and long story short now, the partnership allowed me to identify not only the strengths that were available in resources, but to help me as a leader to understand how to respond appropriately in a culturally diverse neighborhood and community, and how to strengthen their resources and let them know what's available. So we'll talk about what we did a little bit later.
So, Randi, how did we meet?
Hi everyone, I'm Randi Smith. I'm a trauma surgeon at Emory and Grady Hospital. I've been here for about 6 years, and I love the work that I do because I actually am a little bit unique in that I teach at the School of Public Health as well. So I'm an associate professor of surgery, also an associate professor of public health. And a lot of the education, the clinical stuff that I do, and research really does merge those two careers, like trauma surgery and public health. I do a lot of work with violence and injury prevention. And so I'll let you guys know, I'm from South Central Los Angeles. I've lived in Oakland, California. I've lived in Philadelphia and Baltimore, and now I'm here in Atlanta. And all of those cities across the country really are plagued with violence as a public health problem. And so that really is what sparked my interest in this career path. And when I came here, I was very shocked that Grady was the only nationally verified level 1 trauma center, but now we are the only level 1 trauma center, and the volume is very, very high. So anecdotally, I was seeing that violence impacts everyone across the lifespan. But I was seeing an uptick in people that were being injured by violence, that English wasn't their first language. They were coming from communities that I wasn't familiar with. I'm not native to Georgia, so I was looking it up. And some of our injury prevention efforts are great, but they're only in English and sometimes Spanish. So I reached out to a friend of mine who is an emergency medicine doctor who's also a part of our team. Her name is Amy Ziden. And she does work with asylum seekers and other refugee and immigrant populations. And I said, we need to get information out to all communities, regardless of what language they speak. And she said, you got to meet my friend. And so her friend was Mary Helen. So, again, just kind of like you, I sent an email. Hey, I'm Randi, and we have this thing that we want to do. And I'm not familiar with the community. I need partners that are familiar with the community, that can help us to engage, and really make sure that our approaches are culturally appropriate, right? We don't want to go in and think that we know what is best for the community. We need to have some type of landscape analysis and community partners. So reached out to Mary Helen through Amy, and we decided that we were going to collaborate on an injury prevention program, which you're going to hear about, called Stop the Bleed. But just very briefly, Stop the Bleed was born out of tragedy, the Sandy Hook tragedy. So when children were injured by that horrible massacre from gun violence, some of them were injured in their extremities, but there was no one there to hold pressure and stop the bleed, and so they ended up, some exsanguinating. And so leaders in this space, trauma surgeons, emergency medicine technicians, and others got together and said, how can we teach lay people how to stop the bleed in a way that's not going to be daunting? We want it to be for lay people. And then we want them to, be excited about this, engaged and empowered, so that they can go on and just continue to perpetuate the education. So one of our lovely residents, he's not able to be here because of a family emergency. He was on the panel. His name is Jarir. He's Somali. When he was in Seattle, Washington, where he's from, they adapted Stalkabli in the Somali language, and was very well received. Not only, I mean, just think about it. If you haven't been exposed to any of these resources, and then there is now like, you know, attention and intention where people are trying to give you this education in your native language, it actually built a lot of trust between the community and the hospital. And I feel like that oftentimes is a gap that we need to bridge. And so I said, and he came to me too, and he said, let's do this here. I said, let's do this here. But let's first see what's going on at the hospital. So let's see what top languages we have that we're servicing. And you know, from that, we did our first session in Burmese, Arabic, Somali, and Swahili. Then we went on to expand to the Afghan languages once we started to have an influx of Afghan refugees. But it was very well received. And so, again, this is the type of thing that I think AREC is all about, right? Is building these relationships and these community partnerships so that we can take care of people like that's in a culturally and linguistically appropriate way, and just provide them with resources that they would not necessarily have. So that's me and my connection to Mary Helen.
I think we'll do we're going to do a show and tell, and then we'll do questions afterwards. I'll show you. This is Amy. It's hard to get emergency physicians together at the same time because they're always working at really hard times, and they're understaffed, as everyone knows. So Amy actually specialized in refugee health in Pennsylvania.
Yes, in Pennsylvania.
Yep, and there's Randi, and
oh, by the way, Amy and I were in Pennsylvania together, so we're both, yes, so we have that connection, yes. When I was doing my trauma training, she was doing her emergency medicine training, and so we've been friends ever since. I've always been a fan of her work.
yeah. So we have become massive, no, it's fine. I just have to figure. So, Clarkston, we already told you a little bit about, but I just want to go through because I think what Randi said is really important, and I know this is a global symposium, but I always talk about the fact that that global for us is very local. So just like 11 miles down the road, we have one of the most diverse square miles in the United States. The SVI, which is the Social Vulnerability Index, which is the way that the CDC measures the precarity of a community, Clarkston's in the top 8%. So that's sort of like on par with a developing nation. So it's among the most precarious communities in the entire United States. Very similar to the ones where Randi's worked in Baltimore. Oakland is actually very similar, so they're close. So it has high density housing, 30% of adults are uninsured, and I didn't want to put a whole bunch of data in front of you guys. We did evaluate our project, but we really just wanted to tell you the great story of the work that we're doing, but I have all the data, and I'm happy to share it with you. So if you need data and reports, just email me. The half of Clarkston is foreign-born, 51%, and the other half is minority. And I would say that the primary social determinant of health that we have discovered in our community work and our research is, of course, language, as Randi mentioned. We have another research project going on right now with Grady through the Office of Minority Health to help teach people their rights around language access, because it's actually a civil right to have interpretation if you're at a healthcare facility that receives federal funding, but very few people know that. And then the last thing I'll say about Clarkston is that we have a very high rate of trauma. I would say that we probably have the most trauma-impacted community in the United States, based on the fact that not just the migration experience, but post-migration is actually psychologically much more intense from the research that we have learned. And lately, I think we're seeing more trauma than we ever expected. You're a trauma surgeon. I'm like, the Afghan evacuation was a completely unique situation. We brought all of these people here. They did not go through any kind of vetting. They lived on military bases for months. They were not cared for necessarily. So when we talk about health equity, these are all the barriers. This is some show and tell. We have some wonderful clinics in Clarkston that are staffed. Amy actually volunteers at this clinic. This is Grace Village Medical Clinic. They offer completely free care. A lot of Emory folks, actually, med students volunteer at this clinic and public health students. They're amazing. This is our Walk with a Doc program that Dr. Sadia Hassan, who is another Emory faculty member, I love all my Emory doctors, has started, and there I am with my puppy dog. But physical activity is a big deal in our community. So we have lots of amazing things going on. Here's the main event. So we planned Stop the Bleed multiple times, and Randi got really mad at me because I had to cancel the one that we had scheduled right as Omicron was hitting. So we had to keep going back to AGRAC and saying, please let us just keep the money because it's we can't do this in person. But finally we said, forget it, we're doing it. We did it. It was amazing. So you tell this story. There's Stephanie with her husband. She got certified.
So this was really, really important for me because again, this is novel. Like no one in the country has done this before. Again, Seattle has done the Somali language, but to do multiple languages and for it to be smooth and seamless, I'm just going to set the stage. We were in Clarkston at one of the GSU campuses. We were in an area that had multiple classrooms. This is where Mary Helen's office is. It has multiple classrooms, but there's a little foyer in the middle. And we had, people came in, they signed up, and there was breakfast, and we tried to make it very comfortable for them. But we went into the classrooms, and we had 2 rooms going. We had interpreters that were there. So these are interpreters that are from the community. A lot of them already know the families that are there. Omar is one that we talked about earlier. We translated all of the written material into their native languages. So we had, again, the first one, it was Arabic, Swahili, Somali, and Burmese. And we did a translation and a back translation to make sure that we were linguistically appropriate. So we had all these written materials. We even had a pre and a post test. So that's the information that Mary Helen said she has available.
It got published in American Surgeon,
It did.
thanks to Greer.
It did get published. And so we gave the instruction in English, but we had interpreters right there. They interpreted every single line. So in general, these didactic sessions take about 20 to 30 minutes, and then there's hands-on experiences after that. It took us a little bit longer because we're using an interpreter, but that was okay. We got snacks. And then after they did the didactics, we have these mannequins. So you'll see this is someone practicing on a little mannequin where they get to stuff gauze into a make-believe wound. They're holding pressure. And then you see one of our Somali members actually applying a tourniquet on me. So they got to really not only get the skills, like they got to practice them, and then they walked away with a certificate and the gift card, a $25 gift card, and this incredible kit that has a tourniquet. It has gloves, all this protective gear. It has gauze, tape, a pen, so you can write. If you ever have to put a tourniquet on, tourniquet time is important for the hospital, so you can write the time. And so people felt empowered when they left because not only did they gain the skills, but now they have the tools to use them. And so, Agra, thank you. That's where your money went. It was very, very well received. At the end, we did have a post-test, and I'll let Principal Beebe actually talk about her experience and whether or not it was well received. But we did have a little open-ended question at the end, like, what could we improve on and what did you like? And by and large, everyone had a great experience and left with a positive, positive affirmation. So we did it again, and we're going to do it again. People keep asking us to do it in Clarkston, and then also some of the partnerships that we made here, we have then gone out to do many, many more stuff with leads and with community-based organizations. So I would say probably over the last couple of years, Amy and I have taught Stop the Bleed to over 1,000 people.
And thank you very much. I just want to say that like the translating the materials is very expensive,
Yes.
and this is in our community, getting a certificate to our community members is invaluable. Every time we have some kind of training or completion, they want a certificate. It's very meaningful for them. So for us to be able to provide all of this, all of the things that made it such a successful day, I think we trained that day 57 people that day. It was pretty powerful.
The other thing too is that not only did they get the certificate with their name on it, but they were registered through the American College of Surgeons. So this is, they're legit, you know. And I do think that that is also very helpful for them to know. If they ever wanted to put it on a resume, they could put it on their resume. They are trained, and they, you know, they have to do those things in order to get marked off that they were trained. So.
And another thing that we learned that the community really wants more training. They want CPR, first aid, and infant CPR in their language. So we've been trying to think of ways that we could find funders that would be willing to adapt doing that kind of training. I also think there's a serious need for injury prevention training in the community. We have a lot of drownings. We have a lot of children who are burned, a lot of fires, apartment fires, so there's an immense need. I'm going to run through a few more pictures just because the whole idea around today's session was about community-wide collaboration. We do a lot. This was the door-to-door handout that Principal Beebe mentioned. We did, in the early stages of COVID, we knew that the refugee community would be hit hard. So we wanted to be sure communities that could not afford PPE had PPE, and we also translated health information almost on a weekly basis because the CDC always liked to issue new guidance on Friday. So every weekend we were translating new guidance around COVID mitigation and testing and all that kind of stuff. This is an event we did. We went to take it to the people, which is our favorite thing to say. So this is in an apartment complex. This is a specific apartment complex where we had a lot of resistance among Swahili community members who had heard that the vaccine would cause infertility, all sorts of things. We brought a preacher in from outside of Georgia, who's pretty well known nationally, and I think we got 70 women vaccinated that day. We also did a free diaper distribution. Here is Principal Beebe. This is Omar Aziz, who is an amazing IRC community response manager who just got promoted to deputy director, who's another incredible collaborator who does amazing work with us. And this is our great mayor. Beverly Burks has been an incredible advocate for everything that we do in the community, and we're really lucky. So for a community with I wanted to also brag, this is to show you that we worked so hard we talk a lot about health equity and health disparities, and I think I just wanted to share this slide to show that it is possible. It is possible when communities have partnerships and intentional partnerships and work together to close the gap. So Clarkston has the highest vaccination rate of any similar community, and it's actually higher than most of DeKalb County. And that was a lot of work. Stephanie had a lot to do with that. We came up with an idea, my GRA came up with an idea for school-based vaccines. People in our community trust their schools, they trust their principals, and they trust their teachers. We give out thousands of vaccines. And so I just have to demonstrate with a little bit of data that we can do this. This is just a list of a lot of the other collaborative work that we do in the community. We have a summit every year where we invite the community to come tell us what they need. Just like Randi said, we're not about going to the community and telling them what we think they need to do. We do a lot of asset mapping. We do a lot of cultural competency and humility training. We have been able to expand our reach to find a lot more funding, to do a lot more work in the community that we hope is going to continue to close the gaps. One of the things that Randi mentioned that that was funded last week, and I don't think I've told you, I got $50,000 for 3 years to do a Connect to Care project to Grady.
No.
Because all of the paperwork to go to Grady is in English. So if you can get on a bus and a train and come to Grady and get free care, so we're going to have Connect to Care events with perimeter students to get our community prepared to have a Grady card so that they can come to Grady. And then, let's see, I think I just have one more. This is just an example of, it is not just the three of us. It is a very broad coalition. We have almost 40 organizations. We're very connected to our residents, ethnic leaders, faith-based leaders. A whole bunch of people are responsible for this work. That's what it takes. I think before COVID, I would tell you that there was a more competitive environment in Clarkston, and the pandemic, the silver lining of the pandemic was it focused all of us on one goal, and that was to protect people from COVID. And I think that people kind of dropped their competitiveness and their edginess, and everybody focused and worked together, and we were able to achieve great things. Here are, this was the Stop the Bleed team that day. We took there's Dreer.
There's the rear.
He's here with us.
Yes, there.
Yes. This was these are our contact information, which I'm gonna go to one more slide before we have questions because it's my favorite slide of the whole. So Principal Beebe's dressed up as Superwoman for our, I don't know, any other principal. I just wanted to also acknowledge that Stephanie is Principal of the Year in DeKalb County.
Yay!
So that's our show and tell, and we would love to hear any of your questions. Yes.
I know that the Ag grant, you're very generous to give credit to the support that you received from AgRec, but I mean, just looking at what you've done, you must have had other sources of support as well. And I just wonder how what we're doing with AgRec kind of fits into the larger whole of resources for the work that you're doing in Clarkston. And I'm not saying that as a kind of like, I mean, I kind of feel like it's not, what we do is not a lot. Like, it's not a lot of money. And you've done so much.
It doesn't take a lot of money. I think we learned that it doesn't take a lot of money to make if you have high impact practices. Yeah. I think that a lot of times we see government use money inefficiently. But we learned it doesn't really take a lot of money. Stephanie will tell you she doesn't have a lot of money.
I don't have any money. But what I learned from this experience is so what was most important is we had already established systems in our school that they did not have to reach the parents. So, for example, and I'll never forget, when I'm in principal mood, I just tell everybody what to do. So I have all these doctors and surgeons, and they're going, I think we should do. I said, no, you're in my school. This is how we run it. And so the process, because our parents they already understand how you come into school. They understand our modes of communication. We provide translation services already, so that they expect that. So if I already have translation, that's a part of what we do. I already have the student body, and I know how many members are in a family. All you have to do is bring the people in, set them up, divide them, identify how many people per family, how many shots they need, how long, which one you're going to take, and you send them out the door. That is something you don't need money for. We've already done the legwork for that. So it made life easier. I needed someone to come in with the expertise, and I provided that bridge and the trust from that the school offered. So, yeah, we'll take your money, we like it. But a lot of things are already there, and having the resource really just makes our lives easier to get that information.
It's almost like matchmaking and putting
it really
puzzle
is.
pieces
it
together.
Really
It's like if you take all these different, and put them all together towards one common goal, you'd be surprised at what you can achieve. And, you might think that was not a lot of money, but it was a big deal.
It's a big deal.
And I always say our highest costs doing any kind of work in Clarkston are translation. It's always the most, and the Stop the Bleed kits are very expensive. And we really like them.
Yes, I think, there are costs associated with Stop the Bleed. If you want to do it on a larger scale, like we only had, I think, 4 or 6 of those mannequins. And if you want everyone to touch it and like get the skills, you have to divide the groups, and it ends up being an all-day event. If we had more of those, we could have condensed it to maybe 4 or 6 hours or something like that. But the Stop the Bleed kits is what I feel like most people, they love walking away with something. And that kit is very expensive, like $70.
Oh, wow.
Yeah. It's very expensive to have the branding, and then, the tourniquet in there costs, $20, $30, whatever it may be. It's like an expensive kit. So I think we spent a lot of money on those kits. But I think the return on our investment was the trust and the reputation of the program and people wanting to come back. So I think it was well worth it.
And all of the people who ran the program were volunteers. So it was all medical students.
I was going to say time.
Yeah, doctors.
Yeah. I mean, if people had to be paid to do that, that would be
Right.
impossible.
Yeah.
And I also want to add, because of all of the school shootings and the concern for safety in schools, my parents came.
Mm-hmm.
And I had at least, I'll say maybe 10 parents that came.
Your lunchroom lady came.
I know that's right. She sure did.
Yeah.
But what that reminds me is, even though it may not have been relevant until they showed up in the news all the time, we're still getting those same issues, and we can honestly say we are prepared to provide some type of service in case we have a critical emergency and be able to help our students because of this trend.
And unfortunately, we've had mass shootings in Clarkston since then. You have a question in the back.
Yeah. I'm wondering how you all coordinate the activities of all the different organizations. You mentioned the Community Advisory Board, I think that's what it was called.
The coalition.
Or the coalition. Like how does that work? Because there's so many organizations that are working in Clarkston, so many different programs, so many individuals that are invested in Clarkston. I remember some years ago at Emory, they had this event where they invited everyone at Emory who was involved in Clarkston to come together, and I think it ended up being 50 or 60 people from all the different schools, law schools, School of Public Health, School of Medicine, etc. Right? How do you coordinate everyone's activities so that you don't duplicate efforts? And how do the community organizations themselves deal with that? Because you might get calls every day from some really well-meaning individual who says I want to help, I want to tutor, etc. And you're like, please.
Yes.
We already have 50 people.
There's also an ethical component to that. Like, our community is not a lab. It's like we're very protective.
Yes.
It's not a place where people can come experiment. So what came out of the I would say that is a very accurate description of the community before the pandemic.
Okay.
When COVID hit, a few organizations took the lead to assemble a community coalition that was all volunteer. We met every week. Every Monday, we had a Zoom call. It was open. We had a lot of leadership from the mayor, from the city council. And so we had this incredible buy-in, and that has continued. And so now that we are in the stages of developing and formalizing the Clarkston Health Equity Coalition, so that those partners, all of them, and it's everybody. It's Emory and Grady and all the different schools and all the people, PCOM, everybody who's doing work in the community. We meet and we have working groups, and we are investigating and looking for funding to figure out how to intentionally. I mean, I get a lot of flack for saying things. I have a gift from a good friend that says, "Tell the truth and run." I do not. I'm tired of having screening events. I don't think that taking people's blood pressure and telling them that they have hypertension is helpful at all. And that was kind of the standard of care in the community. And so we've tried to make to be really focused on what I just said, connecting people to services, which is what Stephanie, and I know Randi will tell you because she gets them. But we just had a health event at the mosque a few weeks ago, and the focus of the Health Equity Coalition has been, having the community identify what the problems they want addressed are, and providing us coming together and providing those services. I'll give you an example. One of the problems that Amy actually found working in the clinics was that there were very many women who were not getting preventive care, and they didn't want to go to a doctor and be seen by a male doctor. So we started a women's preventive health program at Grace Village before the pandemic. And it's completely staffed by women providers, female nurse practitioner students from Georgia State, female providers. It's in its 5th year. We did an evaluation study. 75% of the women who we saw the first year of that program had not been to a doctor in 5 years. That's connection to care. That's providing, so it's all free STD and HIV screening, everything. We have an ultrasound machine now. And then making sure that those people, in fact, one of them had advanced breast cancer, is connected to a specialty care, which the Northside Foundation and Grady are our primary go-tos for complex specialty care. But really, that's an excellent question. I think it happens a lot in communities that are fraught, and there's lots of people and actors who want to help. And coordinating that help can be unpleasant. Like people can be not nice about it. And I think that the pandemic really actually focused everybody. And so we're hoping that we're going to continue that focus on being very intentional about the work that we're doing.
That's wonderful to hear. I have one quick question, one more quick question, if I may. Because you mentioned also that one of the largest, expensive, one of the most cost-intensive programs was to translate all the documents.
Yes.
I know the CDC is such like a multinationally oriented organization and has documents, resources on their website in many different languages. Apparently, that's not the case for their weekly guidance documents.
Well, I happen to work for an agency that's funded by the CDC.
Right, so I'm wondering, like, what can they?
So there's a difference between something being health literate and accessible to the community, and like Randi will tell you, when we did the translation of Stop the Bleed, I mean, the CDC can issue new guidance. Do you read that guidance? I mean, it's like it's not written for our community that has basic literacy.
Oh, so even if they were to translate it, it's not
Right.
in a kind of language, in a kind of
literacy level.
It's in a jargon that people wouldn't have.
Right.
access.
And many of
I
our
often
parents
can't
don't
understand
read.
it. Yeah.
People forget that. Some of them just don't read.
Yes.
One of the tools that we've developed are animated videos that are audio in language, because so many of our community members don't read or write in their native language.
So I was going to say the material that we had, that we translated for the different languages, there was a lot of pages of pictures, just in case there was some issue with literacy. But most of the time we want to have our materials not higher than an 8th grade level. And when we did our translation and back translation, and then like had our community members read it, it was still too sophisticated. So we, revamped, we added pictures, and I think it was well received. But that whole process takes a lot of time and money. I think it took Iris months to get that together. Yeah.
We have an adult literacy expert who also consulted on this project, who's not here today. But it took, I just generally will tell you that the health information that is produced by the CDC and the World Health Organization and other places is not accessible to the majority of people who need it, especially those in our community. I have a PhD in English, and I couldn't. I was helping people fill out the forms to get their vaccinations, right? Randi would know what the heck those conditions are that are on that form. But I felt responsible for helping our community members understand what they were signing to get their vaccine. I didn't know what it meant. So it's a serious problem that is pervasive. It's a health disparity that is a serious
And we can't
problem.
take for granted too that many of our parents or my community, they come from places where they don't trust the government. So then you have to consider who's giving me this information. Is it someone that I can trust? So a stranger on the street or going to a healthcare organization receiving it is very different than your teacher or your principal saying, this is something that I know, this is something that I believe in and trust, and I'm willing to talk you through it or walk you through it or have any questions answered in a way that is appealing to you. That makes the difference. We forget about the human factor. We respond to people who make us feel good about what we're doing. And so once they are comfortable and we're able to give them that information, I mean, it really takes half of the problems away from the disparity.
Thank you for your presentation. It was wonderful. I wanted you to, wondered if you could talk a little bit more about your idea. This came up, and I'm not sure if you've been able to, if it's been able to take off or not, but like training the trainer, you know, having this model of like, you know, you're in the community, you train some organizations or some leaders in that community to do the training for more members of the community. Have you been able to do that? And is that still something you're hoping to do?
We just did that with a mental health training. So there is an intervention called narrative exposure therapy that has some really good RCT data out that has efficacy in refugee and veteran populations. We just trained 30 community members. The problem with that is that when you train lay people in mental health provision, you still need to have supervision, and we lack, so we just have no infrastructure for mental health. We're working really hard on that in that space. That has been kind of the priority, I think, for the community, whether it's a refugee community or not. And I bet Randi would tell me that the people she sees at the hospital, whether they're refugees or not, the mental health of our nation, and Stephanie, we're in trouble. But in terms of other train-the-trainers, we haven't gone anywhere with that. But if you have ideas.
Yeah, I was going to say that from our last training, there were 2 Afghan members that were there, and one of them had done something similar when he was in Afghanistan. He said he wants to be a trainer, and so when we do our next session, he already has his certificate as a participant. I'm going to have him up there like how Amy and I were. So I think he will probably be our first like trainer person, because he wants to go out and continue to do this in his community. I was just actually looking through a text message of the last time that we corresponded, because I haven't spoken with him in a while, but I told him that the next time we do it, he'll be there with us. So I think that's the whole purpose of Staff Lead too, is that it's supposed to be simplistic but efficient enough to do the job, but then have people be empowered to go out and teach in their community. So I think that would also be a really good example of something that we can do.
You know, we hadn't thought about, it's a great point, thank you for asking the question. A lot of the Refugee Women's Network health promoters participated in the training, and so they could provide training to other community members, once it's done. So I think another kind of side secret benefit that we weren't expecting that Randi alluded to is that a lot of the folks that attended from the community had been health professionals in their home countries, and they really appreciated the opportunity to be acknowledged for their expertise. It was very moving because they are not perceived that way here. They are perceived as people who don't have skills, don't have language skills, and so they were able to show us. There were people who've been nurses and people who've been doctors, and they were excited. They were like, oh, how do we do more of this? And they felt connected to their career and their profession, and so finding ways that we can advance that, I think, would be really smart.
Avenues like people who may have been medical professionals in their own country to enter the health.
Oh, and I want to do a plug for how many people we vaccinated. So there were, a was it 1,100? Over 1,000 actual vaccinations for COVID, which led to how do we get regular children vaccinated or get the regular shots for school and immunizations. So now that whole project has moved to making sure our children are healthy for just regular everyday school.
1,000 for the students, or
It's the families. So we had 4, I think, events, and there were 1,000 shots in the arm, over 1,000.
That was a special part too, because we made it a family event. I felt like it was more acceptable among mothers and grandfathers and uncles and young people. You know, the group that was the most resistant were the young people, like the teenager, college age group. But when people came as families to get vaccinated, everybody was
And
there.
it was incentivized, so I don't want to make
Yeah, we did have incentives towards the end.
And what we also don't talk about, but is also important, is as an educator, our teachers were deathly afraid to go back to work. A lot of teachers quit because they were afraid of having children in the classrooms who were not vaccinated. And they didn't want to get sick because many of them had, they were caring for people at home, or they had elderly parents or small children. So just explaining to my teachers that the more families that are protected makes our school healthier, and our absenteeism won't be as high, and it wasn't, because many people didn't get sick because we're so densely populated. If everybody goes to the mosque down the street and nobody is vaccinated and they get sick, our families aren't small. I have the average family is about 3 or 4 children and 2 parents, at least 1 or 2 parents. So that could really take out my whole school if somebody gets sick. So it made everybody feel better in coming back and just dealing with the random concerns behind COVID.
I think the other thing we don't talk about, and unfortunately we have to talk about now, is that, Randi, how many shootings have there been?
So last year, we have the numbers for last year, we had 11,000 trauma activations, which means that these are the people that your trauma team sees. They're not the folks that maybe just get by the emergency department, patched up and sent out. And a quarter of them were due to penetrating trauma, which the vast majority are gunshot wounds. So, I say a lot of times a quarter of a large number is still a large number. That's where we are, and only going up. Our numbers are getting higher with the closure of AMC. So, and they come from all across the city, including Clarkston. So we have a lot of work to do for violence prevention.
One of our collaborators in the community is a Clarkston former refugee, Haval Kelly, a fellow at Emory. A lot of people know who he is. he showed up to cheerlead and went, "I want one of those kids." And then he said, "Everyone should have one of these kids in their car." And the truth of the matter is that every school teacher and every school employee and every single person, whether it's on this campus or at Stephanie's campus, ought to have this training. It is as critical as first aid and CPR, and maybe more so. And I think that we're very grateful that we were able to do this, and I hope that we can do more. And that's the unfortunate situation, but the way that we can do something to address the gun violence problem, especially in our schools. And when I think about the children in Nashville that died, and I think about being a principal and being responsible for the lives of those kids, this is something that we can do, and it's important to do, and it actually does save lives. So,
And it was a wonderful training.
yeah, and we really, really loved it. And thank you very much.
Yes, thank you.
Are there any other questions? Well, thank you so much
Thank
to our
you.
panel.
Thank
And
you.
the work that you are doing is so inspiring, and we're happy that we can help out in some very small way. And we will keep following you and hearing about all the wonderful work. always let us know, about any other upcoming projects.
Yes.
We can get the word out.
And if you ever just want to do something great for a school, my school is Indian Creek Elementary.
Yeah, do your plug now.
Yeah, that's right. We would love to have you.
She already signed me up for career day.
Yes.